point that what affected the survival was the AALC, not the machine. When we look at 2-year progression-free survival, and you compare the whole group, those that collected AALC less than 0.5, 50% were free of cancer at 2 years, versus almost 80%. If you look at the modify, again, if you collected less than that, it was 45 versus 76. And if you collected at the standard, it was 58 versus 85. But if you flip the coin around, let's say, okay, let's look about patients that collected less than 0.5 and compare the modified versus the standard, or patients that collected more than 0.5 and compare the machine, did that affect the outcome? And the p-values were the same. So it's not the machine, it's what we collect that we give to the patient. So what was there? Another factor that affected the AALC, besides the machine. This reached the ears of the 5th Lord. That's why they say it was a great disturbance in the 4th. So, if we look at other factors, if we look at the CD34, our target was 5, so it was balanced. Interesting, both collected the same, all right? But there was another factor that we could not control in the study, and it was the number of collections. Because by that time, the target for the CD34 was 5 million. So, because if you were here or here, you collected the CD34, 5 million in one collection, then you're done and you go to transfer. If you collected in 3 collections, then you're done, you go to transfer. Or you collected 5 million CD34 in 8 collections, you were done, you go to transplant. So even though there were balance, the question that we had, could the number of collections, the more collections that you do, can also collect more of this? Because if that is true, you say, okay, we can still manipulate the machine, but if we do more collection, we can reach the target of the 0.5 to affect survival. So we look at the number of collections. So again, we're going to compare patients that collected less than 4 versus more than 4. And if you look at the cohort, the whole group, if you collected more than 4, your AALC was reached at 0.5 or above. If you compare per arm or per machine, still the same. If we flip the coins now to look at only the people that collected less than 4 collections to see the machine affected the AALC, and just people that collected more than 4 to see it affected the AALC, and there was no difference with that. But you know, there's an irony of everything. Because, as I say, remember, it is not how you collect, it's what you collect that matters with that. Either by manipulating the machine or by the number of collections. But the irony is that the 5th Lord wanted to suppress this knowledge. And way back in 2005, the AAC Alliance sent this paper. The number of collections affected the AALC. And did not get published. But if we look back then, patients that have more number of collections, the AALC was higher, and that translated into survival that we see. Like anything else, you always feel more rewarded if somebody confirmed those findings. So this other group from Australia, looking multiple myeloma, and the higher the number of collections, the higher was the lymphocytes they collected. Here they use a 0.12 cutoff, but higher lymphocytes that you give, survival is better compared to those who did not. But we want to know more. So besides the AALC, we'd like to know what type of lymphocytes are doing this. And those who know what it is, that's part of the mythology Star Wars. But we look at different type of lymphocytes. We look at CD3, CD4, CD8, and we look at NK cells. And interesting, higher collection of NK cells besides the AALC affected survival. Why do I bring this up? Because as we make this practice change with the AALC, and we're still doing research, most likely we might be able to tailor more to collect these NK cells to affect survival better. And if you want to use fancy terms like individualized medicine, you can talk about individualized apheresis collection. I think that's pretty exciting with that. So that will be something kind of down the line that we're working on. for me with that. So, based on this phase 3 trial, that's why we made the change of practice with that. Now, I use the 0.5 because that's what we published, but I show you other people have used 0.3 with that. And also because this not only applies to lymphoma, also can apply to multiple myeloma and so forth. So I wouldn't be surprised that probably down the line we might extend this to other diseases too, in that regard. Now remember, there's 6 lords coming too. So be careful with Dart Hatchme who left, Dart Hogan, Dart Patnick, Dart Litsa, because they always believe more in the graft versus host disease than this. So if that happens, just let me know. Now, why does this really matter? Because I'm here talking to you, and you guys like me, I hope, and you believe me. So, preaching to the choir. But are there other people outside Mayo looking at this too? Okay? This is the paper that we just recently published. This is a phase 3 trial, it just came out. But papers are coming out from different areas outside Mayo looking at the same thing. So this is a paper that was published just recently a year ago, where they say, there's more to the graft than the stem cells. And it's based pretty much on what we published here. This is another paper that came from Sergio Urat, who was in MD Anderson, now is in New York. Well known in bone marrow transplant. Again, looking at perennial cell lab, but again, Mayo, ALC 15 with that. And just to let you know, there's currently a multi-center trial in Finland where they're looking at day 15 recovery, but also what is in the other graph to see that affects survival. And they published this paper recently. This is a prospective paper. That again, if your ALC 15 is greater than 0.5, survival is almost 90% versus that. So this is the research why we came to this idea. Any questions from this?
How much is there an interplay with perhaps there are some people who have better survival and that correlates with higher lymphocytes in the graft? Is it the more lymphocytes in the graft versus some other factor intrinsic in the patient that helps them collect more lymphocytes but also improves survival? I'm just worried about the patients that are struggling so hard to meet the lymphocyte targets.
Yeah.
Are they just set up for failure regardless of how long we collect?
I mean, the best way they can tell you, the phase 3 we balance for all the clinical factors we had. When we look at the retrospective data, when you look at other prognostic factors, specifically for lymphoma, like something called the IPI, it was independent. Performance data was independent. If the patient was in CR or PR powered to transplant, was still independent with that. Now, so far we had done, I think, 10 patients. There were a few patients that took a little bit longer to collect the ALC. One of them that I went to see in the apheresis machine ID, I forgot that he was a renal transplant, so the patient was on CELSA. So that definitely will affect the collection, even though we might do 20 collections or so forth with that. The other factor, and I think you're probably right, is the age of the patient could be a factor. Also, how many prior treatments they have before with that. I think the other one was another patient of mine, was a pretty young guy for Hodgkin's. Recollecting was close to 0.3, but that poor fellow had more than 5 or 6 prior chemotherapy regimens before hit the floor to collect the number that one. So I definitely believe there are some factors that affect that age, prior chemo with that. The other thing that we might be looking for, interesting, plerixafor also mobilized lymphocytes because they block the signaling. So in the patient that we had done so far, if we look at the number of AALC collected, well, they're on plerixafor and G, is definitely higher compared to when we stopped those two drugs. The problem that I'm facing right now is not a academic problem, it's more an insurance problem. Because so far insurance only approved to use G and plerixafor to collect CD34, not to collect lymphocyte. Because I will be very worried that if I continue to use the G and the plerixafor, insurance might not pay. And I said, well, you already collected your $4 million, why are you still giving the drug? with that. But that will be something that we can definitely tailor down the line in that regard. Like any change, there's always some bumps, and I know you've been guys through this and talking to me. So one of the things that being addressed is, should we lower the 0.5 to 0.4, but even though we get 0.4, we can get to 0.5, that will be good enough, just to minimize the number of collections with that. Definitely that's something that we will talk about, but at least we talk to the patients from the other side, because when we made the switch, a lot of the patients, that switch happened before the patient knew the switch was going to be made. But now you guys know, they say, well, my doctor mentioned, but I don't understand this very well. He said, if we do this, we can improve your survival. We can improve from 50% close to 80%, but using your own good lymphocytes.
What machine do you think is going to get that faster? Have you looked at the Optia?
Let's Master Jedi Burst Starter.
Yeah.
I know my limitations.
It doesn't collect more lymphocytes. The trouble with the Opti is it has enough baggage of its own. It does not like heparin, so trouble using the heparin cocktail, which means we get more fluid, more citrate back. It also heats up platelets. And in a case like this, we're not going to use it because it won't take any time at all. We'll deplete all the platelets before we ever get to the lymphocyte target. So the only way it would work is if it was tremendously better than the Optis. But we're still looking at it.
I have a question as
Yeah.
far as staff and education. Now, the patients usually see you, the primary physician, after our vein eval, correct?
No, usually, for example, for any patient that comes to transplant, they do have an initial consultation.
Yeah, but how far advanced of the vein eval is that? Is that like
And that could be like a month before,
month?
2 months
Yeah,
before.
okay, so that's your plan to talk about it then?
Yeah, and right now, the only people that we do in this are called lymphoma patients.
Right.
So all the lymphoma transplanters know about it with that. But I learned you never assume anything. So we are right now telling the patient, when you come for your transplant, besides collecting your CD34 for this, we want to collect your lymphocytes because we have evidence that improves your survival benefit.
Okay, so then it'll take time, because I know
Yeah.
I've heard that some patients come and they haven't heard about it yet.
And what I was saying, that group of patients probably happened before we made the switch. So
Yeah,
they
the
know
ones
about
that
it.
came for collection, but
Yeah.
now when we're seeing the vein eval,
Yeah,
they haven't quite heard it,
Yeah.
but it will happen.
yeah.
Okay.
With that. I think the thing that we'd like to tweak is the cutoff of 0.5 when we do the order. Should we make it a little bit, 0.3 or 0.4, with the hope to still try to get to 0.5? Because Ed sent me an email with the first 10 patients that we have done. I think 7 collected 0.5. I think it was in 3 collections, which that was the average. What we published people vote before was 4 collections. And I think the people were 0.3, there were 3 that needed 5 with that. And I think one of those were a patient was in CELSA, so that will gonna minimize your lymphocyte. The other patient was a patient of mine that was heavily pre-treated. So I know that his stem cells now is being hammered. The other patient, I don't know what it was with that, but on average, look at 3 collections. We're doing very, very well.
If you look at our layers of blood as they're layering in our centrifuge, whereabouts